Treacher syndrome. Here in this video, we'll try to cover Treacher syndrome within about 20 minutes. So in this, I would be covering about an introduction briefly with epidemiology and later with history and in detail about clinical features and its management. Okay, so this is mainly from an article which is treatment of Treacher syndrome, which was in B Jobs 2014. Okay, so let's begin. Treacher syndrome is also known as mandibulofacial cystosis, Franchitti-Wallen-Klein syndrome. Okay, it's mainly a defect of first and second brachial arch. Okay, the epidemiology of this is 1 in about 25,000 to 50,000 live birth. Male and female population are equally affected. Okay, so talking about the history, Thomson and Toynbee in 1800s had described Treacher syndrome for the first time. Later, in 1900s, the same was described in detail, and it was by an ophthalmologist, and who named it as Treacher after his name itself. Okay, it was his name Treacher, so the syndrome was also named same. Later in 1944 to 49, there was a brief study and description by Franchitti, Klein and Swallen, and they named it as mandibulofacial dysostosis. Again, talking about this, recent advances, there is more about genetics and there is defect gene which is identified, and further researchers are going on the patient specific management or gene targeted treatment of these syndromic patients. So let's talk about the clinical features. The clinical features of Treacher syndrome can range anywhere between just a lateral maxillary dysplasia to a zygomatic temporal auricular mandibular dysplasia, which is very wide. So it can just extend from maxillary hypodysplasia to a very extensive one, which involves maxilla, zygoma, temporal region, auricle, and mandible. Okay, so this can be put into Theseus oblique cleft, which is 6, 7, or 8, or a combination of all three. So let's talk about the facial features. So here are the features. Mandible is micrognathic, okay, and a very striking important thing. When a patient walks into your clinic, you'll have to note about these things. Treacher syndrome is bilateral and asymmetric. Okay, so this is very important and key in identifying a patient with Treacher syndrome. That it involves bilateral and it is symmetrical. Okay, mandible is micrognathic, malar deficiency is present, hypotelorism is seen, lower set ears are seen. Okay, these are very striking features with low slanting, down slanting eyelids. Okay, lateral palpebral is low slanting, so this is another striking feature. So let's talk about description of each unit in detail. So talking broadly about face, mandible is micrognathic, bilateral and symmetrical involvement is noted, parotids are aplastic or hypoplastic, pseudo macrorhinia can be seen. This is mainly due to your deficiency of malar region and your supraorbital ridge. And the temporal region, there is sideburn hair, so which is seen in about 25% of the patients. Usually your hair faces from up to down, right? But then in temporal region, but in these patients it is from down to up, it faces upwards. Okay, sideburn hair on cheeks and temporal regions are noted. And another important very striking feature, that is malar deficiency, is noted. Coming to the eyes and eyelids, which is the first aesthetic unit we'll be looking at, and the functionality also we'll be looking at. Here in these patients, there is lower eyelid aplasia. Okay, there is lower eyelid aplasia, and there is short or down slanting lower eyelids. Sorry, the short or down slanting palpebral fissures are noted, and the globus retropossession. Hypertelorism can be seen. Okay, coloboma, which is the notching of upper and lower eyelids, are seen. Okay, euroblepharon is also noted. So what is euroblepharon? So you have a patient's eyes. So usually the eyes is like this, right? And your eyelids and eyelashes comes here itself, right? But in these patients, your palpebral conjunctiva is seen and it's retracted, and your eyelids are seen here. Okay, so you can see that pinkish conjunctiva here. Okay, this is uriblepharon. Okay, anywhere the extent can be vary. Okay, So notable features in eyes and eyelids, there is lower eyelid aplasia, short or down slanting palpebral fissure, globe retropositioning, hypertelorism, coloboma, which is the notching of upper or lower eyelids are seen, uriblepharon is seen. Talking about the mouth, there is macrosomia. Cleft palate can be seen in about 33% of patients, so it varies. Okay, anywhere between 25 to 33% is noted. Again, which is about one fourth of the population with Treacher syndrome has cleft palate. Okay, high arched palate can be seen. Vilopharyngeal insufficiency is noted. Dental anomalies are seen. The tongue is hypoplastic or retroposition. Okay, so talking again, let's summarize it. Macrosomia, cleft palate in 33% approx. VPI, vilopharyngeal insufficiency is noted. Palate is high arched. Dental anomalies are seen. Tongue is hypoplastic or retroposition. Talking about the next unit, that is your airway. So airway problems are mainly secondary due to your mandibular micrognathia. There is also another reasons, which is corneal atresia, which is a blockage of your nasal passage, which is an emergency to be treated. And there can be tracheoesophageal fistula. Again, it has to be treated immediately. Okay, small nasal airway passages can be seen. Yes, again, this can contribute to your airway problems. Okay, so because of all these things, there is difficulty in airway. Okay, difficulty in respiration. Okay, coming to the next aesthetic unit or functional unit, that is your ears. So talking about ear, there is conducting hearing loss. Okay, there is bilateral conducting hearing loss in about 50% of the patients. So when a patient with Treacher syndrome is identified, it is very mandatory to assess the auditory system itself. Okay, and when we talk about the neurological status of the patient, they have normal intelligence with two things, that is conductive hearing loss can be seen, and vision loss is noted in few patients. Okay, and when we talk about other clinical features, the external ears are small. Okay, and there can be tags, extra tags can be seen. Okay, external auditory canal bilaterally can be stenosed or atresia can be present. This is again a very striking feature of Treacher syndrome patient. There can be small low set ears. Okay, and the external auditory canal can be bilaterally it can be stenosed or atresia can be seen. Okay, there can be extra ear tags and fistulas which is noted in and around your ears. So mainly these things are noted between your ear and the commissure of the lips, which again is suggestive of one of the oblique tissue cleft. Okay, so talking about the next one, which is your treatment modality. Okay, so before that, let's just have a look at this CT. CT shows your progressive, brachycephaly of the brachycephaly with temporal narrowing is seen. Okay, hyperteloric eyes are seen, and retropositioning of globe will be secondary to this. Okay, zygomatic hypoplasia is seen, rudimentary paranasal sinuses are noted, mandible hypoplastic and retrognathia is noted, and then your antigonial notch is marked and dominant, and mandible condyle it's very striking. See, there is flattening and it's very hypoplastic. Okay, so again, this is another very important feature, and there is unpneumatized mastoid air cells. Okay, okay, let's move forward. So let's look at the management of Treacher syndrome. So the management of Treacher syndrome is done under four phases. So the first is urgent or emergency phase, and the second is infancy, and third is during childhood, fourth is during adolescence or after maturity. So the various treatment which comes under each phases can be remembered with the mnemonic Treachers, wherein TR stands for trachea and airway adjustment, E stands for eye protection, and under A comes infancy comes ACH, that is angular osteotomy and destruction of mandible, C for cleft palate, H for hearing, and under childhood comes your E, which has two, that is ear reconstruction, second one is early orthognathic surgery or mandibular procedures. Okay, coming to the adolescence and after maturity, you have two things, that is R and S.
reconstruction, and soft palate. So remember it with a mnemonic, that is stretchers. So it starts as stretchers. So the first one, that is your tracheal and airway adjustment. So this, as we have seen, the airway complications are noted with few of the patients who has trichocolon syndrome. So depending upon the severity of airway compromise, we will have to go for either the, when it is very less prominent, you can go for no support, but when it is mild or moderate, you go for nasal prongs and nasopharyngeal airway. But when it, even in, like when in severe cases, you might even have to go for tracheostomy. Coming to the eye protection, correction of the uriblepharon and hypoplastic lower lid. As you all know, eye exposure has to be reduced to protect the cornea. So corneal exposure and potential scarring can be reduced by doing this. So this comes under urgent or emergency procedure. The next is in your infancy. So during your infancy, you go for angular osteotomy or distraction. Again, when there is airway control, we'll have to get airway control, we go for this. This is in the case of extreme retrognathia, okay, but otherwise you can go wait till a maturity or during childhood. Okay, and the next one is cleft palate. So you know that at 1 year or after 1 year, depending upon the weight of the kid, you go for cleft palate correction. Okay, so this has to be done during the speech development itself, so that the speech of the kid is also unaffected. The next one is hearing. So hearing, the prominent, I mean the important thing that you'll have to remember is 4, because at 4 years of age, after 4 years or at 4 years of age is when the temporal bone, cranial temporal bone thickness at least reaches 4 mm. So why is this 4 mm important? The 4 mm, if it is only that thick, you can go for holding, I mean it will be capable of holding osteointegrated implants. So until then, I mean till 4 years of age, you will have to go for early banded hearing aids. So this usually starts at 1 year of age, because the kid's speech develops only if they can listen. So at 1 year of age, you're going to give banded hearing aids. At 4 years of age, when the cranial temporal bone reaches a 4 mm thick at least, you go for a holding, I mean osteointegrated implants. So the next one is again about ear itself. So ear reconstruction, as we have seen, with the patients with trichocolon syndrome have a range of deformity of ear, that is pinna can be normal or cup shaped, lobule microtear can be present, or total anosmia can be seen. In such cases, you will have to go for reconstruction. So that has, I mean, you have two options for that. The first one is autologous rib cartilage reconstruction at or after 9 years of age, and the second option is implant retained prosthesis. So you either go for one of these. Okay, the next one is as we have seen, after 4 years of age, you go for bone anchored hearing aids. So that is also done during the same time. And coming to the adolescence or maturity, two things. Very importantly, reconstruction part. Every reconstruction card comes, and the second is your soft tissue refinements. So under reconstruction, you go for orthognathic surgery of mandible, maxilla, or both, and genioplasty, stuffs like that. Okay, and also you go for malar augmentations. Okay, in these patients, because malar deficiency is prominent, you go for malar augmentations. Okay, the next one is rhinoplasty. You go for rhinoplasty definitively after all these skeletal procedures are done. Okay, to get a proper orientation of how what is to be done with the nose, you get an idea only after the skeletal procedures are done. So that's planned after all these orthognathic surgeries are done. And finally, you go for soft tissue refinements. So this includes your mid face lifts and lateral canthopexies. So these are the things which you have to remember with trichocolon syndrome as a basic thing. Okay, and yeah, I hope you understood. Thank you.